invited to this outstanding meeting, and I heard some of the really excellent discussion previously, which just overlaps a little. So I'm going to try and move in 20, 25 minutes through a discussion about maintenance strategies. I'm focusing on acute myeloid leukemia. So this is an area of major interest now, not only in patients who have received intensive chemotherapy, and that's quite new, but also patients who've been transplanted for AML. And the reason is, as we know, that patients who relapse either after chemo or after transplant have a very poor outcome, so everything should be done to prevent that occurring. So the guide and key, really, to developing effective therapeutic strategies is to understand as precisely as you can the disease biology underlying the process. And so I think it is important when we're thinking about designing maintenance strategies, either after chemo or after an allograft, to be aware of the significance of clonal evolution as a major driver of resistance. And this was a study that we did with Parish Vars's group in Oxford. And it's one of the only studies where patients have been prospectively examined using NGS at diagnosis, prior to transplant, and if they did relapse after transplant. So you can see we looked at 113 patients, of whom 49 had relapsed post-transplant. And in those, we found 29 patients in whom there was a sample, and we were able to do and compare the next generation sequencing profile at diagnosis, prior to transplant, and relapse. And essentially what we showed was the majority of patients, they have quite distinct molecular profiles at relapse compared with diagnosis. And so if nothing else, this is telling us that we can't rely on diagnostic features to inform a targeted maintenance strategy. Let me just show you some of the patterns we found. I think they're quite interesting. The first was kind of reliable recapitulation of the molecular phenotype at diagnosis at relapse. So that's the top calendar there with the same pattern of WT1, NPM1, and FLT3 mutations at relapse. But we did find other patients who were really very different. There were patients in whom there was clonal evolution at relapse that wasn't detectable prior to transplant. But also, interestingly, look at the bottom left-hand corner, patients in whom chemotherapy itself had exerted clonal pressure. And there was a distinct clonal footprint prior to transplant that was subsequently recapitulated at relapse. So look in the bottom left, you had patients developing a F6 mutation at diagnosis that dominated at relapse, but that wasn't present at diagnosis. And then bottom right, this is a patient who had a small but detectable TP53 clone prior to transplant after induction chemo, which was the dominant clone at relapse. I think that's really interesting. I think that gives you some insight into the sort of maintenance strategies you might want to develop, whether you want a broad or a focused, targeted strategy. I think it also emphasizes the importance of mutation analysis post-transplant and pre-transplant in terms of informing what you might use post-transplant. And lastly, it does mean that it may be misleading for us to be doing risk stratification for patients destined to transplant at diagnosis. Maybe we should be risk stratifying patients on the clone that is present after intensive chemotherapy. Just a thought. So I'm going to talk just quickly about maintenance strategies outside the setting of transplant. I think they're important and they're relevant. So azacitidine has been looked at as a maintenance in patients who've had intensive chemotherapy for AML for a number of years. And the reason for that is it's a very interesting drug in terms of upregulating epigenetically silenced tumor antigens, cancer testis antigens, WT1, a whole bunch of antigens. It even actually, in the context of transplant, upregulates minor histocompatibility antigens. And that's particularly interesting because we showed in one of our phase 2 studies with valproate and azacitidine that just the application of that combination therapy induced a sizable CD8 T cell response to tumor-specific peptides, but not the control population. So I just want to rest the idea with you that it may be that by applying maintenance outside the setting of transplant after chemotherapy, that you might induce an autologous anti-tumor response. So going now to the clinical data, well, there was really quite provocative data from the HOVON data set presented in ASH 4 years ago, which showed that patients who'd had chemo were deemed not eligible for transplant, who were randomized to receive AZA maintenance, 50 milligrams per meter squared for 5 days for 12 cycles, actually had a survival advance, had an improved disease-free survival. There was no survival benefit because many of the patients who relapsed crossed over, as happens. But this was provocative data and kind of was the underpinning data for the AML-001 study, published in the New England Journal of Medicine a couple of years ago, where using an oral formulation of azacitidine, CC486, which has a distinct pharmacokinetic profile, was administered as maintenance therapy in fit adults who'd had intensive chemo, but for whatever reason weren't proceeding to transplant. So this was the randomization. It's a very select population of patients, actually, age 55 or more, de novo or secondary AML, intermediate or poor risk cytogenetics alone, who were in first CR or CRI after either a single cycle of intensive chemotherapy or 2 to 3 cycles in total of chemo. So they were randomized to receive maintenance therapy as is outlined there, and it was a placebo randomized study. So I think to some people's surprise, actually, this showed a significant improvement in overall survival in the population of patients who got CC486 maintenance. The curve comes together, we'll talk about that in a bit, later. So it doesn't look like you're getting a significant number of patients who are achieving a very long-term benefit, but clearly a significant survival benefit on the basis of these data. And sorry about that, this side always does that. So the patients who are NPM1 positive did particularly well in this study. And interestingly, the survival benefit was observed whether patients were MRD negative or MRD positive. So that study has informed licensing approval for CC486 in patients who are in remission, who are not proceeding to chemotherapy. Interestingly, in the UK, that has been a very broad, permissive licensing indication for any adults with AML who've had intensive chemo, regardless of cytogenetic risk. And I think one of the other questions that is raised is that a significant number of people in this study only had 1 or 2 courses of chemo. So how representative are they of the general population? But those points aside, the generalizability of data and the number of people who'd had only a modest number of courses of chemo, I think this is a very important development, because for people either who don't wish to transplant or who cannot proceed to transplant, and we know that inability to access donors is a particular issue, particularly in certain ethnic subgroups, then this provides an additional, potentially highly effective treatment option. So I just wanted to show you a couple of slides. We were interested in this question about why was it that patients who have a therapy for high-risk MDS or AML, why do they always relapse? So we wanted to quantitate leukemic stem cell numbers in patients who'd had azacitidine. I just want to show you these data. I mean, it's a bit old now, but they get quoted a lot, and I think for good reason. What we were able to demonstrate is that in patients who treated with this was in AZA and vorinostat, this was a study we did, who got either of those, either AZA and vorinostat or AZA monotherapy, obviously no reduction in the stem progenitor numbers if you don't have a clinical response. But interestingly, in the patients who achieved a CR or a CRI, you're almost always still able to detect leukemic stem progenitors. So I've proposed biological insights, I think three probably. One is mutational instability. Secondly is induction of CD8 T cell responses by drug therapies. We need to explore that further. And lastly, the importance of sequential leukemic stem cell quantitation to understand the biology of disease resistance. So now to turn to the main purpose of this talk in my last 12 minutes, which is how might we use maintenance strategies to improve outcomes of patients allografted for AML. I don't need to tell this audience that allogeneic transplants now pivotal curative strategy. We have reduced intensity regimens. We have increased unrelated donor panels. We have cord. We have haplo. So most people who we think should have a transplant can now proceed to a transplant. The challenge, of course, remains disease relapse. And whilst there's been a substantial reduction in transplant-related mortality, particularly using haploidentical donors, which are turning out to be a very important stem cell source, disease relapse has not changed in incidence. When it occurs, we know it occurs early. More than 80% of those destined to relapse do so in the first year post-transplant. And as I've said, your outcome after relapse is very poor indeed. So we need to think about pulling out those patients who are likely to have a high risk of transplant, because that might shape either how we transplant them or actually what we do in terms of maintenance. And these are the important factors. The other piece of the jigsaw that's been looked at perhaps a little less comprehensively, which is relevant when you're applying a maintenance therapy post-transplant, is the kinetics of relapse. So in this study that we did with HOVON and the EBMT, we were really interested to look people who'd had an allograft, were the particular factors that drove rapid relapse, because that could inform when you might start maintenance therapy. And this is what we found in the multivariate analysis, that the factors that were driving early relapse were the presence of a FLT3 mutation, older patients, and a long time to achieve relapse, complete remission, drove early relapse. And interestingly, and use of an unrelated donor seemed to protect you. So we also then looked at people who relapsed later, and the people who relapsed later, it's interesting this, I can't explain it, but they're people who had a mutated NPM1 and also patients who had in vivo T cell depletion. So I think all I'm saying here is we need to be really thoughtful about stratifying patients at particularly high risk of relapse and also pulling out people at a risk of early relapse. So conceptually, what might we do to improve outcomes by reducing relapse? Well, I'm not going to dwell on the opportunities to reduce pre-transplant MRD status. That's plausible. We need randomized trials of agents that might do that. We haven't historically had such agents, but I think Ven-based regimens, particularly, the Air-Ven-Aza triplet might be interesting in that context. The conditioning regimen could be important to, is there a Cinderella conditioning regimen with not too much toxicity and just the right anti-tumor activity? There is interesting data that using cord blood in particularly children with high-risk AML, very nice paper from Rob Wynn's group in Blood Advances yesterday, is associated with reduced risk of relapse, and that's not the only paper. There's some Seattle data. So I think we must continue to explore the optimal stem cell source in this setting. But the last, of course, is to maximize the graft versus tumor effect. So looking just briefly at MRD, we've thought about this a bit in our group. So the retrospective data, this is the first data, the Iraqi retrospective study, that showed if you were pre-transplant MRD positive, you had a really high risk of relapse. It was the same as if you had refractory AML. And other retrospective studies, they're flawed, aren't they, these retrospective studies? You don't quite know when the MRD was taken pre-transplant. You don't know what the technology was. You don't know why certain people had MRD done and certain people didn't have MRD. But they showed a variable size effect. So we wanted to explore this issue at the same time as looking in patients having reduced intensity regimen, whether there might be a Cinderella RIC regimen, and we were in a randomized study exploring the benefit of the Flamza, the sequential regimen developed by Christoph Schmidt and Hans Kolb. So this was patients AML, CR1 or CR2, randomized to receive either Flamza abuse, their conditioning regimen, or essentially people got FB2, Flubu2 using the French regimen, stem cells infused, primary endpoint, 2-year follow-up, 2-year survival. But Sylvie Freeman in our group very brilliantly did prospective pre-transplant flow MRD, never been done before prospectively on all these patients. We were disappointed to see that this intensified regimen, that means people are in hospital for another week, have more toxicity. There was no improvement in survival in any subgroup. So that's interesting because it's been previously widely used in AML CR1, but when you actually did a randomized study, there was no benefit. The second thing that Sylvie did, which was very nice, was, yes, she confirmed that by flow MRD, there is an increased risk of relapse. That's the red line in patients who are MRD pre-transplant. She showed that the cumulative incidence of relapse doubled from 20% to 40%. But importantly, I think in this study, we showed that actually even for the MRD positive patients, if they're in CR1 or CR2, they still actually did quite well with the transplant. Their 2-year overall survival was 51%. 70% if you're MRD negative. But we again would, in our group, would be saying the data would suggest that if you're MRD positive, there's no rationale for not proceeding to transplant. What you need to do is try and think post-transplant about strategies to reduce the risk of relapse. That might be a rapid cyclosporine taper, mightn't it? Or it might be DLI. And relevant to the maintenance discussion was these exploratory data that we pulled out from the Figaro study, showing, look to the right, arm B, panel B, in brown, in patients who were pre-transplant MRD positive and didn't achieve full donor T-cell chimerism, who had mixed T-cell chimerism at day 100, their risk of relapse was much, much higher than those patients in the aquamarine who were MRD positive but achieved full donor T-cell chimerism. So our interpretation of this data is it's another piece of evidence that there's a very potent graft versus tumor effect that we might exploit using maintenance strategies. The other piece of evidence, of course, is the typical one. This was from a RIC population we did with the NCRI group, showing patients with high cyclosporine exposure had worse overall survival because of increased relapse compared with patients with a lower cyclosporine level. Both compelling pieces of evidence to say there's a powerful graft versus tumor effect post-transplant. Can you do anything to maintenance? And just to finally close out on the conditioning regimen question. So these are a study that's just closed, having randomized 290 patients, looking at TBF versus FP4, and we're waiting for the results from that study. So let's think about post-transplant maintenance. How might it work? Well, I mean, we showed in the previous study that azacitidine improves outcome, but there's still residual leukemic cells. So if you had a pharmacological agent that targeted leukemic stem progenitus, that would be perfect. But the alternative is that you actually just delay that and you buy time for this graft versus tumor effect. And so what's that principle look like? Well, it takes a while for a graft versus leukemia effect to be clinically operational. I mean, either transplanted donor CD8 T cells take a time to expand, or your CD8 T cell population from the transplanted donor stem cell takes some time. And it's perfectly possible that relapse occurs before you have a clinically significant or meaningful graft versus tumor effect. So if you had an agent that just pushed relapse back, maybe that buys you the time. I mean, ideally, we'll talk about this in a minute, if you have a drug that augmented a graft versus tumor effect, that would be nice. So the previous speaker very elegantly talked about post-transplant sorafenib and FLT3 inhibitors. So I don't want to replicate this. He mentioned the retrospective data, and this is the Burkett data. It's been replicated in a Chinese study with a survival advantage if you have post-transplant sorafenib. And I thought he commented it very accurately that these are quite small populations, but there was a survival benefit. Trouble is, sorafenib is not very well rated post-transplant, although I think it is possible to deliver in a number of. So it kind of doesn't solve the problem. And interestingly, one of the pieces of evidence to suggest why sorafenib may work is that this was a nice paper in Nature Medicine, it can augment production in FLT3 positive cells. So it may actually drive T cell expansion. Just thinking conceptually how this drug might work. We're all waiting, of course, for the results of the Morpho study in 10 days' time. I suspect that we will have some very provocative data and that it will not be entirely negative. So we were interested actually, partly because of our work showing considerable mutational instability, about not so much a targeted maintenance strategy, but a mutational agnostic strategy. So azacitidine is interesting in that setting. I've shown you how it upregulates tumor antigens, but we're also able to demonstrate that it accelerates Treg reconstitution. So this may be a very interesting agent, both in terms of anti-tumor effect, augmenting GVL, but also reducing GVHD, which led to Mohammed Moti coming up with this very nice diagram. So sub-Q is jolly difficult to administer post-transplant. There has been one randomized study done. It was negative. Patients didn't see much AZA. So we were interested in using CC486. We established, this was work with Marcos de Lima in Seattle and New York. We established an MTD, which was 200 milligrams for 14 days. And we randomized patients who'd had an allogeneic transplant for AML and CR1, who were in remission post-transplant, to receive azacitidine 200 milligrams for 14 days, or they got randomly assigned a placebo. The primary endpoint was 24-month relapse-free survival. I'm delighted to report to you that despite the COVID pandemic, we randomized and recruited on time, 326 patients. The study was closed out March this year, and we hope to have results in about 18 months' time. The alternative approach, and the heading hasn't come up, the title hasn't come up, is a study called VRLT, which is actually using sub-Q-AZA and oral venetoclax. That study is recruiting well. So my conclusion is we need increasingly to think about identified patients who are going to have a high risk of relapse and those who might relapse early. We need to think about tailoring maintenance to mutational profile. We need to be thoughtful with post-transplant maintenance therapies, whether they're targeted or a broad anti-tumor specificity, that they are well tolerated by patients, that particularly post-transplant, you can start them early, and they need to be validated in randomized studies, because it is possible that maintenance pharmacological agents could blunt a graft versus tumor effect. And increasingly, we need to understand more about the factors driving these incidences of relapse. So I'd like to end it there, and I'm very happy to take any questions.